Okay, so we're just going to go over some quick techniques in regards to opening sterile packaging to us on the field and to each other. We're going to demonstrate how to, Lydia and I kind of have slightly different techniques, so we'll kind of go over quickly how we do it. Lydia's technique, I think, might be more favorable for a lot of the nurses. So I'll have her start with how she opens gloves.
So the gloves, when you start opening with the gloves, and if you start from the middle, sometimes or quite often the flappy edges of the glove package will turn inside, and those edges will touch the gloves.
Contaminating the glove.
Contaminating them. So what you need to remember is to have control over these flappy edges, both of them. So what I do, I usually start from here, from my side, and I'm holding the edges, and I start opening it this way. I keep my eye on the gloves, and I move slowly towards the other edge, and this way, and I'm not like turning this like sideways. I keep it straight, very, very straight. And if you do this, and you have control of these edges, the gloves inside are not contaminated. So the scrub can take it from you this way, or you can like this, or you can open it to the field. Try not go over up to here. You just kind of open it. Now you can use this. The new gloves are a little bit more difficult. Do you want to show your, these are a little bit more difficult because they have a pocket on one side.
So you're going to make sure how I open this
side? Yes, go ahead and show
how I open this is very similar, I guess, because I was trained to start from the middle. And I use all of my fingers underneath to control the edges from going in. So I'll come and start in the middle, and I'll just kind of pull out. See, the corners are still on the out, not going anywhere in. And then I'll just kind of from there, and then so my lady can pick it up. She can take it from the field, or from here. So you can actually stand pretty far from the back table, and you can just pop it. And your arm is covered from here as well, which is an option. Now these new packets are a little bit trickier.
Yeah,
they have a lip all around the sides.
Exactly. So what I try to do, again, the same way. And somehow I think I usually have this packet where the gloves are on my this side. I don't know. I don't pay attention, but I think it is what I do. And then I will use my fingers to pop it out from this packet because it does get stuck here. And then I will open it or pass it away or just open it this way. It's a little bit trickier, but...
So basically you have to use your fingers from underneath to kind of shove it out of its little pocket before it can go on the table and
have it. If you keep your eyes all the time on if it's a glove or if it's an instrument, if you keep your eye and you can see, because everyone contaminates from time to time, but you need to be able to recognize that you did. You know, you just need to be able to say, oh, I'm sorry, I contaminated this, let's open another one. But in order to realize that, you need to look at it and know which areas are sterile and which not. So everything inside this mark where it was sealed, everything inside is sterile. Anything like outside, if you touch this outside, if you touch even like here, it's with the glove or instrument, it's not sterile anymore. So we need to open another, whatever it is, another.
And I think Lydia is correct in thinking that whatever your dominant hand is, so if you're a lefty, maybe you can open it. So basically the hand that will control how you're going to push the glove out of your pocket. So if you're left-handed, open it with the clear side on your left hand. If you're right-handed, open it on the right. So I'm the same, I'm right-handed. So I'm going to open from the middle. I'm going to control my edges. And then I use my pinky and I pull back. And then that right there should be enough to get the glove.
Enough for somebody to
grab
it.
But then you kind of have to finagle it out, and then you can just push it out, kind of like that.
And again, with as far as you can from the edge of the stair table. You can't go over. Even if you need to try, even if you just, as less as possible. Sometimes it's impossible, but you can't go over like that, or even with your hands.
Depending on the
pouring water,
circumstances.
pouring some nothing. This is like a glass here. You can't pass with your hands, whatever you open to the stair field.
I usually have the nurse come around to my side. So like, here's the OR table, here's my Mayo stand. I will just have them come behind me so they're nowhere near my sterile field. So that's always an option. There was one thing Lydia had mentioned earlier in regards to opening. Sometimes opening faster can create more time and contaminate, so you have to go grab new gloves and then bring them back. Sometimes being slower and more just, like she said, paying attention, you can get it done in one try. And that could be just as quick. So once you get those edges under control in your hands and open, then you can just be fast and they can just come and grab it. So just kind of keep that in mind. Even though we're like, hurry, 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 you can be like, I'm hurrying, and just and we're like, okay. Now,
I don't know, seems like if you open instrument, pill-pack, and there's another pill-pack instrument, there's another pill-pack inside.
we call this a double peel pack.
But its technique is actually exactly the same.
It's exactly the
glass.
same, right.
It just, the package is longer. You have a longer edge to control. But as long as you know the technique and you are good at whichever you choose, there's no difference.
There was one thing that we didn't mention earlier. So when you say you grab an instrument, grab this, the corners of each of the packages are going to be stuck together. So I normally, when I come in, I'll grab the middle and I'll take my thumb and get rid of those edges, because sometimes people will open from the middle while the edges are still stuck in the corners, and that makes the cave-in. So come in, get those edges free, and then you can start to open. And it's an all peel packs, gloves, this. So those corners, just make sure those corners are free.
So should I open this one?
Yeah, so the double peel pack is really great because if you contaminate opening at the first bag, you have a second chance with the second one.
So this one is a bigger and heavier package.
It is,
Okay,
and it's awkward.
So, and this peel pack is sticking right out there. So I have to look at it and make sure that I can touch it at the outside of the package, and the bigger one, don't touch it. So this one is the easiest way to just pass it.
And then just right there is just good, and then the scrub can come in and grab from the middle and pull it out.
And again, you see, I will be watching this edge here because it's really close. It's really close to the outside of this one. So the easiest, would be the best will be to pass it to someone. But if you have to open, it's difficult.
Pull with one hand.
Like this.
Yeah. So did you see how she held one side, and then the other she controlled with one? So once you get it open, it started, then you can maneuver from there.
And of course, this should land on the sterile field. If this, because it can really actually, the paper might or might not break, but if it's on open sterile field, it's still considered sterile, the whole package. And if you somehow it gets contaminated, you have another chance, you can open just this one. If something happened, you touch this, and it's not good anymore, the outside is not sterile anymore. Oh, I wanted to show you something. Like when she was saying about the edges being still sealed, if you do this with anything actually, and go like this, so a lot of times usually you just go inside. This is the whole point here, and yeah, you just have to do like this. So this is the second chance to open that capacity.
Okay. So,
You want to add something with this one?
Yeah, I do. So sometimes we'll get it like that is a large awkward object. We have instruments that'll slide on the inside, and those kind of terrify people because when they open it slides and then contaminates. Sometimes if you can control your hand movement, so I just got the corners. I'm opening using primarily my right hand. I'm opening. There's that. Now this is where I'm going to do, where you can kind of hold the instrument in place with your hands so that it doesn't slide as you're opening it. So let's say, it contaminated, okay, get a second chance. Sometimes these corners get tricky. See, like this right here, that happens. That's okay as long as you can get it to make sure that the instrument doesn't touch that corner as much as possible. Tricky, 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 and if it's open, like I'll just use my fingers. You can use your fingers to kind of just sort of control the placement as long as it's directly in the middle. Does that make sense? Are there any questions right now about this? Okay, so then this right here is good because then scrub can come and grab it. And then you can probably try and pop it on the back. Hopefully you won't have to, the scrub can just grab it from you. So is that, are we moving too fast? Are we making sense? We're good? Okay, now we're talking really quickly. I just wanted to talk about envelope folds, because usually I'll be talking to theirs like, okay, it's an envelope fold, and you're like, I don't know what that means. So basically, the majority of our packaging for sterile supplies is going to be in an envelope fold. If it's like this, just automatically take it out of this package. Just take it, don't worry about it, throw it away. This is what you want. So the trick is, it looks like an envelope. There's always going to be a tongue right here. So there it is. Always stick your thumb underneath that triangle, right? You see? And that allows you to control what's in your hand. Always grab from the tip, loop it around, put it between your fingertips so that the lip doesn't come back and contaminate, because it's now contaminated because I touched it. So always, and you come from the side, and you always want to pull from under, because you pull over, you can contaminate what's inside. So pull from under, come around to the side, tuck it. And you can move this to get a better angle, so I'll move it this way, tucking it in my hands. Grab from underneath. Oops, there's got a little way, but it's okay, you can do that, and then you can hand it to us. So all these edges are tucked in my hand, prevents it from coming back and contaminating. So if I say it's an envelope fold, immediately look for that triangle and the tongue. So it's the same thing for gowns. You can see the tongue, right? So automatically, thumb underneath, protect, pull, over, in your hand, in your hand, in your hand, in your hand. And then you can even, still everything's sterile, you can sit on the table, throw it on, however. So I'm like, it's an envelope fold, and you all will know what I mean. Look for the tongue. Okay. Are there any questions about that? No? Okay.
So how many people in this room have ever been a patient in the hospital? And how many days did you just want to languish here and not go home? Probably not very often. So our patients feel the same way. Just right there. And so Hilda and I sat on a committee a couple of years ago to try and decrease the length of stay. And discharge begins, what's that? Who's going to? Okay. So discharge begins on admission, and this is primarily for the labored nurses because the postpartum nurses do this all the time. Explaining this parent pack will take you 10 minutes or less, every single piece of paper, and so your patients know what they have to do to get the heck out of Dodge, and we're not slowing up the discharge process. So it's primarily for labor nurses because postpartum nurses do this all the time, and I don't know if it's that people don't know what to tell our patients. 2 years ago when I oriented to postpartum for 2 days, and it scared the Jesus out of me, Melissa Camacho told me what I needed to say to these people. So this is thank you to her. So I just sit down at the bedside, and I will do this if I have a meso patient. I'll do it during my postpartum recovery if my mom is eating lunch or she's eating breakfast. Like I said, it takes you 10 minutes to get through. So just a little side note, when they come in and you have them fill out their permits, put here the pediatrician that they're going to use, because the HUC needs to know that for some of the testing that needs to be sent away. So make sure you put the pediatrician. If they may not know a name, if they know a clinic, that's what we need to know. Okay. So before you go home from the hospital, you're all my patients now, but then I'll direct it to you. There are certain things that you are going to need to accomplish before you go home from the hospital. These are listed here. There's certain things that we have to accomplish before you leave, and they're listed here. Everything can be started prior to the delivery of your baby. We don't know the date or the time that your baby is going to be born, but you can fill out all this information. And so, Mrs. Dick and Mrs. Allen,
Which one of the babies?
I don't know which one had the baby, but you're both looking stellar. All of your discharge teaching is going to come out of this book. If you have a mama question when you go home, you're going to refer to this. If it's not answered in here, you're going to call your provider. Likewise, if you have a baby question and it's not answered, you're going to be calling your baby's provider to get those questions answered. While you're here in the hospital, you'll be rounded on by somebody from our leadership team, making sure that everything is as your stay is expected. If you have any questions or concerns, or something is not up to your standard, feel free to call on your landline or your cell phone and talk to one of our charge people or our unit supervisors. Not that you're going to have any time when you go home, but here's a comment card, good or bad, especially if there's anything that we can improve on. If we don't know what we're not doing right, we can't make it right. While you're here in the hospital, we do have a newborn channel that you can look and see what is current for baby care. Not only is it in English, it's also in Spanish. So while you're waiting for your baby to come and you have questions, certainly different topics you can learn about. This is called the period of purple crying. Every baby is going to cry for no reason whatsoever. This is an initiative to prevent shaken baby syndrome. You're getting frustrated at home, put your baby in a nice, safe spot, walk away. They will not remember the crying fit. It's going to be much harder on the two of you than it is on the baby. What's that?
She can take care of that baby.
Okay.
I'm going outside.
Okay.
And my mom always told me to do that too, just go outside.
Okay, this talks a little bit about breastfeeding. And so I always ask my patients whether or not they're planning on breastfeeding or not. But discouraging the use of pacifiers while your milk supply is coming in. So this talks a little bit about that. We have different resources throughout Snohomish County that you can contact on an outpatient basis. We also have breastfeeding experts here in the hospital. If you have any issues, comments, questions, we'll call in the lactation consultants, and then you can also see them on an outpatient basis. Then on Thursdays, we have a new lactation support group. Make sure that they have a car seat. And then this is an information sheet on how you can safely get your baby into that car seat. And then there's different places throughout Snohomish County where you can have your car seat inspected. It is not something that we offer here, but it is highly recommended. At the time of the delivery, we are going to be offering 3 different medications. First medication is erythromycin. Babies will pick up bacteria during the birthing process. So we put erythromycin ointment in their eyes to help prevent infection. Second medication offered is vitamin K. When babies are born, their livers are immature. They have a much harder time clotting their blood. We want to help prevent brain bleeds, and especially if your baby's going to be circumcised, we want to make sure that that bleeding stops. Those are the 2 recommended after delivery. We also offer hepatitis B that you can either start here in the hospital or you can start in the pediatrician's office. And if you choose to start it here in the hospital or you're wavering on which area to go down, then we can also print out the CDC guidelines. Back in the day, before we had computers, we would write all of our immunizations on this piece of paper. Thank goodness we don't need to do that anymore. The reason we need to know who your pediatrician is we will be doing a blood test called a PKU following delivery before your baby goes home. Those tests are described here for certain metabolic disorders. That blood test will be sent to the state of Washington. Those results will then be forwarded to your pediatrician. So that's why it's so important that you have a baby provider prior to leaving the hospital. We'll be doing 2 checks, 2 screenings on your baby prior to discharge. One will be a hearing screen. It's not unusual that they don't pass. It doesn't mean that they failed. It means we need to repeat that test. Babies are born with extra fluid in their ears, and sometimes they just don't pass that first round. We'll also be doing a congenital heart defect screening. We'll put an oxygen probe on this arm, make sure that the same normal oxygen level is on the opposite lower extremity. Both of these tests will be done at the bedside. We offer a new fatherhood class. Unfortunately, it's not very often. However, one is coming up July 7th. And then we offer a grandparent class. And I thought this was pretty funny because I didn't kill my own children the first time around. However, when I started nannying for Tressa's twins and I had an orientation day, I was so overwhelmed with the equipment that we stayed in one room the first 3 days. I watched these babies, and it took to the third day when I realized that the baby monitor that was on the counter, I could actually pick up and bring to where I was sitting because it was wireless. So things have changed a wee bit, and my baby slept with a bumper pad and animals and blankets and on their stomach. So that's the grandparent info. As far as infant security, while you're here at the hospital, anybody who takes care of you must be identified with picture ID. Nursing staff will have a green stripe, medical staff will have a red stripe. Make sure that somebody is always identified. The reason this looks like this is it is my natural hair color from 30 years ago. After babies, right? Yeah, okay. After baby's delivered, there will be 4 sets of bracelets. The baby must be identified with the mother's last name. Mommy will have one, daddy will have one, baby will have 2. One on his arm, one on his leg. He'll also have a GPS tracking unit. You get that tracking unit within 5 feet of any stairwell or exit, you'll hear a click and the hospital is gone into lockdown. Nobody can get anywhere. Don't believe me? Grandpa did it. Dr. Sharma got stuck in the stairwell trying to get to a delivery, so it really does work. If you're out walking with your baby must be in a push bassinet. We've got too many pieces of equipment, cords, wires, tubes. We do not want anybody falling. The only reason your baby should ever have to leave your room is to either 1, go to NICU, or 2, go for a circumcision. Otherwise, your baby will never leave your bedside. Then, if you are not legally married, prior to leaving the hospital, we would like for you to look over the paternity paperwork. And if you have any questions regarding the paternity or any issues in that regard, we can have social services come and see you if you're unsure how to fill out this form. We can go ahead and witness this while you are here. The biggest piece of information that's going to get you out of the hospital the fastest is this Washington State birth filing form. It must be filled out before you leave the hospital if you wish for us to file it. You can go ahead and fill this information while you're here in labor. You cannot give the birth date, time, and measurements, but everything else will be ready to go. All of your discharge paperwork will come off this piece of paper, your verification of birth. So it's very important that this is turned in as quickly as possible. You want to make sure to mark the box, do you want to get a social security number for your child? You mark yes, otherwise you're going to go down to the Social Security Administration office and sit with a whole bunch, and I can say this, gummers there, because I had to do it with a friend. And so make sure that you get this filled out. Then, I'm really saying
I didn't know what a gummer was. I didn't know what a gummer was. I had to ask. Got it. We knew.
So then, yeah, 6 to 8 weeks out. I mean, if you make this work for patients, so in about 8 weeks, you're going to send away for 1 certified copy of your birth certificate. You only want to pay for 1, and then you can just make copies at home. Any questions about your parents?
So I just want to come by and let you know about the ARRIVE trial. Anybody hear about the ARRIVE trial yet? Yes. Okay. Good. Perfect. Anyway, so the ARRIVE trial is a large trial that came out in August of 2018. And on here I just summarized 61,000 low-risk women. It was multi-centered across the nation, some teaching universities, some not, okay? And it was a randomized controlled trial comparing expected management group, those waiting for labor to begin on its own, and intervening only if problems occurred, so induce if something came up, versus the other group was assigned to elective inductions at 39 weeks gestation. Important to note, strict protocols were in place in regards to definition of active phase of labor, and what constitutes failed induction, kind of like our safe delivery roadmap work that we're doing in Washington State, where active labor is 6 centimeters, what is latent phase, how much time should you give before you call a cesarean. So in this trial, it was very important that they follow those strict rules, so we're not just doing cesareans willy-nilly, okay? And then the sort of outcomes, the main takeaway, there were no perinatal mortality or severe neonatal morbidity differences between the two groups. So again, that's the elective induction group at 39 plus weeks versus the expected management group. And to us, that have always been like, let's not induce, let's not induce, let's not induce, unless we absolutely need to. The next information is what was really significant and is changing sort of the obstetrical arena right now regarding inductions. So what they found actually is that there was a lower cesarean rate in the elective induction group, so those at 39 weeks, versus the expected management group, and it was statistically significant. So 18.6 versus 22.2%, and then also lower rates of hypertensive disorders, probably because these patients were waiting to get hypertensive disorders, right, as their pregnancy progressed. And then lower rate of respiratory support needed by the newborns in the induction group compared to expected management, which kind of makes sense to me, right? As you go, there's more meconium, as the baby gets older and starts pooping. Anyways, so this came out in August in MSPT, which is our forum for leadership and representatives from nursing and physicians, etc. We're like, oh, what are we going to do with this data? What does this mean to our healthcare system here at Prob? And just as what ACOG and the Society for Maternal Fetal Medicine said was, it is reasonable for obstetric providers to offer an induction of labor to low-risk women 39 weeks plus after discussing the options thoroughly in the shared decision-making model. And women have to be, it says first delivery, low risk, and 39 weeks. And I kind of liked what they wrote here in the quote. A collaborative discussion with shared decision-making should take place with the pregnant woman. Additionally, as induction of labor involves coordination between the healthcare provider and infrastructure in which induction and delivery will occur. I think that's an important part. So, how would we implement this here when we already know we don't always have enough staff, we don't have rooms, etc.? Okay, so how are we going to take this recommendation and then apply it systematically? That's the big question. And I just want to make sure that you guys know that we're having these discussions because we're getting patients that know about this data now. And they're super interested in being induced, of course. And so, the data's good, what are we going to be doing if we're denying these people? And then they have about outlook, about outcome happening. So, thoughts?
So these are just for primates?
It says primates in the study, interestingly enough. And the other thing that was really interesting, it doesn't matter on cervical ripeness. So they can have, Bishop's score 3, and they still had better outcomes. Had a lower C-section rate in the induction group. Now, what I found out, because I went to ACOG's national meeting this year, just at the beginning of May, is it increases your length of stay by 6 hours, though, however. doing these elective inductions. And length of stay, of course, to us means a lot. It means we need to have more nurses, or how do we go about that, you know?
But if it lowers your C-section rate overall, are you making up for that on the hindsight?
Right, so what the study does, or what they kind of summarize at the end, is we don't know the sort of cost issue. Right, what is that cost comparison and outcome to? What would it mean for the hospital? What would it mean for staffing? So.
And was there ripening then induction of labor? Or was it just?
Both, all inpatient.
All inclusive.
Both, so very interesting. What we've been thinking about in the background is, okay, well, how are we going to decrease length of stay on these low-risk women? We could consider doing the outpatient fully bowl.
Yeah.
So that's why you've been hearing that talk happening, but it's not in place. So especially as charge nurses, if you hear or a provider trying to get somebody on, you know, electively, because they're going to do an outpatient fully bowl ripening and then come in, we don't have it figured out yet. So that's still getting denied at this phase. What it does in my mind though is on these softer call medically indicated ones at 39 weeks, I'm like, we should probably get those softer calls in if we can. But that makes it hard on the softer call ones, which Lisa sent out a communication regarding, you know, subtext methadone, which technically hasn't been an indication, but some of the providers have considered it one of those maternal conditions, and it's been sort of this iffy thing. And I've seen some get in for induction and some not, and we're like, this is an interesting part of sort of the background in the study, right? Which is, on these soft call inductions, we should probably get them in if they're 39 weeks. So, anyways, any other thoughts? I know, it's a lot to do.
Well, just, you know, people are going to be banging at the door more than they already are. I had a gal in triage the other day who was insistent that she was going to be induced, that she'd been told she could. And she was 38 and 3, even though she was 4 centimeters.
Yeah.
It was her second baby, and she was miserable. And I'm like, and then there's some miscommunication or misunderstanding that she thought she could just get put on the books. And I said, well, you can't get put on the elective list until you're even 39 weeks. So
Right.
next Monday, you could get put on the books. So,
Yeah.
you know, it's just, they're coming up on, she wanted to kill me.
Yeah.
She told me she wasn't coming back to Providence. And I said, it's not us, this is from ACOG.
Yeah.
It's a lot.
Well, you know, at least the 39 weeks is super important. And in the second statement, they talk about that. For sure, still 39 plus weeks, so exactly. But it will be tough because patients are hearing about it. You know, it was in the New York Times and all this, so. Anyways, thanks for letting me share.
Oh, what about stripping membranes at less than 39 weeks? Because I've been seeing that more and more, which then we get more triage visits, and they're not in labor, and then there's therapeutic rest, and why is it being done?
Right. Technically, it's not an official method of induction.
Well,
But we all know it can work sometimes. I try to, at least with midwives, I try to tell them, like, wait till 39 weeks. Now, if somebody has something brewing, hypertension or something, they might be doing that, right? Like, when are we going to induce? It could be at 37 weeks or whatever, you know. They might be trying to, if they have a diagnosis kind of coming up. But 39 weeks is better, I think, to wait.
well, it doesn't work most of the time.
Yeah, exactly.
They're just miserable.
Yeah. If they're 38 and like 3 or 4, sometimes we're like, oh yeah, you're close enough, whatever. You know. But good question. Yeah. Awesome. Anything else?
So just right now with the fully hold, we have put that basically on hold during our peak census time, so that you don't have that automatic, let's put on the induction for the next day. Because we recognize and we just want to add some electives. Right now we're kind of stretched thin. So that has been put on hold, and that message I believe did go out.
I saw it go out. Yeah.
As well.
Yeah.
So, you know, if it's done in a clinic setting, we're not necessarily following up that they're automatically put in. It could be that if they saying I had the fully load, it came out at 8 this morning, I'm supposed to receive an induction. Not necessarily, it's going to be based on when we manage the patient at the time, but really it's,
And that's for the 39 to 41. The 41 or 30
right,
or
but
the
that
40 and 6, that's still,
at that.
yeah. And then on a background to that, we feel like, oh, it's so important to do an induction the next morning to follow up on the fully bowl, but there are places like Harvard that, I think it's Harvard, that are doing outpatient ripening with no induction the next morning to follow. They're like, well, good, we got you to 4 or 5, good luck. And then hopefully labor spontaneously. So
There's a lot of studies out there.
there
going on
is,
with-
yeah. So, we'll see, right? Because that might be the way to get around this 39-week and 0-day induction is like, oh, I'll get you right. And then maybe you'll come in based on that, trying to put a spin on it a little bit. So, okay, cool, thanks.
All right, so we went over the caregiver experience survey at our last staff meeting. Where am I supposed to be? Yeah, okay. So what we wanted to do is we kind of isolated some things that people were wanting or part of their experience here as staff, and we had made some plans, and so I want to revisit that and show you guys what we've been doing to try to reach some of our goals for the engagement survey. So these are some of the things that I'm just going to touch on because we already went over them. The strengths and opportunities, we're doing pretty good at in these areas, but opportunities are having sufficient work, staff, information to do your job, and the confidence of long-term future in this organization. So those are the things that we focused on. So what's in the white is what was last time that we shared, and the yellow is kind of where we're at now. So we talked about what are the things you need to do your job effectively currently. So one thing that was a concern is not having equipment, things that weren't ready and available to be used. After delivery, spent too much time tracking down wheelchairs, carts, lifts, etc. So we haven't fixed all of it, but what we're working on is we've created a waste and equipment committee, and there's still room for members if anybody wants to be a part of it. I've had 3 or 4, and it's going to be an amazing group of people. And we're just looking at different processes for improvements where we have waste. I did not bring my card in, but I have. We have people working on the linen waste. We have people working on the plastics that are over all of the equipment out there. How can we change that? How do we decrease the amount of waste in the OR? We're going to have new recycling. So there's just different things we're working on to make to look into our equipment. As far as tracking down wheelchairs, carts, and lifts, that's something that's still on our to-do list. Staggering inductions, that's done. The times have been staggered for nights and days. The trash bags is a big thing. You didn't have the equipment available. So EVS has now given us access to the trash bags. Some of the equipment things that we have available, we've ordered and we'll be receiving 3 more infant warmers and 2 more nitrous oxide. All right, so we don't have sufficient staffing. I know this is a big issue, but these are some of the things that we've really tried to do throughout the year. So a better balanced schedule. Some days are still heavy and some are very light. So we're working on positions, balancing of shifts, bringing some people to days that then nights were short. So we're waiting for approval right now for our next resident and fellow cohort, which I would assume we might have something back this week. Oh, good, yes. Self-entered chrono scheduling was one of the requests that we had. So the over full days were grayed out. Chrono scheduling is halted right now. So I put it out on the weekly updates, but just so that everyone knows, right now they're not able to support kind of the dynamic needs of our department and the layering of different experiences and different areas of expertise. So for now, we're going to halt and continue on the scheduling that we have now.
Just an update, they are building a program that will give some specific classifications in our department, like charge nurses, triage, labor. They're building it. They're just not yet completed in our department. So we will be going to Chronos. We're just on hold a little bit longer, giving the Chronos team time to sufficiently create a program that will work for us.
So you said it was requested, Chronos scheduling? was
We had a
requested?
few people on their engagement surveys, when they said, what ideas do you have, ask for Chronos scheduling.
Did they?
Yeah.
Who are they?
There were.
I think people from Colby.
No, that might be.
I haven't heard that from anybody.
They're smaller units and they're not used to, you know.
All right. So as far as more staff and scrub techs, we have hired 2 scrub techs, Donovan and Daniela. So we were fully staffed, but we've since had somebody who will be leaving, and so we'll be looking to replace that position. We have hired 8 experienced nurses on nights, and I've listed them there. If you guys haven't all met them, those are the 8 that we've pulled on. We have Christina Ashby, she'll be here in June. As far as residents and fellows, we had a new cohort start at the end of April. These are the ladies that are a part of that, so if you see them in the station, say hi to them and welcome them. And then we have 2 travelers that have signed on for nights, and they're ready, and they'll start in June. 3 more positions are open on nights and 1 on days that we're still looking to fill.
And we do have one more coming in June, Colette.
Oh yes, we have Colette too.
She's on there.
She is here.
Yeah.
Colette's coming in June too, so we'll have 2 more experienced nurses coming to nights. So I know it feels like we're always so stretched, but we have been making moves to get our experience on nights. And we have 2 positions always open on our nights in case experienced people apply. We'll always be able to bring them in. Feel supported by my senior leadership. So no one knew who senior leadership was. Tammy, everyone Tammy and above. So if you're on your next review and it says, who's your senior leadership? It's Tammy and anyone above that. What does it look like? What does senior leadership look like? Making rounds on the floor, saying hi, personally seeing how we're doing. So these are the things that people were saying it looked like to have a leader. Tammy has been rounding, bringing out muffins and such. Janine and the new CNO will be rounding in June as well. So just be aware that that's going to be happening, and you can meet some of the senior leadership that way. Coming soon to an OB near you. So I'm just going to put the 2 topics together, what's coming. So we have one thing that was mentioned is that you guys didn't have the education, and so we put out the monkey survey, and you guys all gave me information on different topics that you wanted education on. We put those into brown bag lectures, and we've been scheduling them. We started them at the beginning of last month. We'll be having the next brown bag lecture, I believe, next week. So anyone who's interested in coming, you can use your education time, clock in under education if you'd like to come to these. The event or the topics are always on the weekly update, so you can pick whichever ones interest you. Peppermint aromatherapy, we still have a couple things to research before we go with that, but we have ordered peppermint. Some people have talked about having it for voiding for our patients after they deliver it. We just want to make sure all the evidence supports before we go live with that. We are looking, and we have put in SBARs for new fellows and residents at the beginning or at the end of July. So we're hoping to start our next cohort at the end of July, and so we'll see if that was approved, hopefully. People were worried about rounding. I have been checked off on the rounding. So if it's crazy and you guys need a rounder and I'm in my office, come by and snag me and I can help you guys with rounding. The Equipment Waste Committee has started working on all these areas. I'm so glad that Lori was here. Lori has been going through the rooms and weighing. This is clean linen from rooms over just a few days, isn't it? And they all have, I want everyone to be able to come up and see these because she's actually nicely dated and weighed all these things. So we pay per pound for linens, and we're just looking at ways that we're wasting. And so she's done a great job pulling all this together so that we have a visual representation of the waste. I think sometimes it's easier to see that. And so just one of the big things that has been mentioned is we have all the supplies like the Perry bottles and the linens and everything in labor and delivery. We take them down in postpartum and they have a Perry bottle and they do have witch hazel pads and they have all these towels. So how can we make it so that we're not wasting so much? So that waste committee that has started to really start to look and identify these areas, and then we're going to look at find solutions. So if you're interested in any of that, please talk to me and I will put you on the committee. So we have a new triage workflow with the new phone messages. Hopefully that's freeing up some of our triage nursing
The operator is transferring people who call in up to triage. At least this weekend they did.
Well, then their education needs to go back out to people as
I
well.
think we had at least 3 calls transferred up to us yesterday.
From the operator?
Operator.
Okay.
So if they hit
Option
4,
four.
option 4 will transfer them directly to. So if they listen all the way through, option 4 will get them straight.
So what are we supposed to do with this phone call?
If they are, the only reason they should be pressing that one is to let you know they're on an imminent delivery to the floor. If they are not and they call in, then just give them the same
That's the
info.
operator, right? You said
Well,
The operator.
one that I received yesterday was, it said on it, operator. Would that be from, I thought that was from the operator.
That's
Would it be
That's from
option
zero.
4?
It's just
It
an
could be
outside,
either.
it could be an outside.
So we can make a message to the operators just to
Just
refresh
remind
them.
them.
And then also if they call and they have any of this, if you're 20 weeks or less, you can, the ED, if you're 20 weeks over obstetrical, please call your provider. Same thing that's on the answering machine, just give that to them because we're not going to be triaging patients.
Right, so that was what I did, but.
Perfect. So we can reach out to operators, make sure that they're on the same page.
Okay, thanks.
Engagement tablets, we talked a little bit about that kind of they'll be coming, they're in the mail. We've already had, you might have seen in some of the postpartum rooms that the brackets already mounted in the room. They're going to be always plugged in, they're always going to be charged because they're forever. So that'll be nice, we don't have to worry about their charging and all. I know sometimes they've gone down, we've had to put passwords in, so we're going to try to make the password the same password you guys are using for everything else, which I don't know what it is. But try to use a password that everyone uses for other pads and such. So that it's easy, yes. So I talked to Kashif, and he can reset it to whatever 4-digit password we want that everyone already knows. So we are going to be going live with Eat, Sleep, and Console in 35-week neonates in the fall. However, in the meantime, we are working with NICU and pediatricians, and we're going to be sending out information videos to you, hopefully on a weekly basis, with little tools and tricks on these babies and how to care for them. We want you to be as prepared for these babies when they get there, and then at the next staff meeting, again, we're going to do a big education on it, and we're going to bring pediatricians in. But I want you guys to get as much time, answer questions and all of that before we go live, so just be aware that that is coming. And on your weekly updates, there might be video links, and we're going to be tape recording them. I don't know that they're going to be super professional. It's just going to be us doing some education, but we're hoping that that will make everyone feel really comfortable and confident starting this process in the fall. So still, I said this from the last time you guys saw this video slide, but I'm going to say it again. So what can you do if you want to improve the engagement or improve the unit? Join a committee. If there's something you're passionate about, join a committee, create a committee, come in and talk to us, help us solve the problem. Lead an improvement project. If there's something, this linen right here is one of those projects where there was a passion behind it, and now we're able to identify a waste, and now we're going to work to try to improve that. Teach a class or a skill. I have a lot of these brown bag lectures that I am happy if you're really interested or passionate in a subject and you want to teach your own people that you're working with, by all means come to me and we'll get you signed up on a brown bag lecture. Really important, if you're seeing something that's not working or something could be better or in any way, please talk to your supervisors. Everyone has a supervisor that they do their success factors, and or you see a supervisor on the floor, please talk to them because they're helping me to find improvement projects on the floor, and we won't know something's broke unless you guys let us know. So if it's a system, a process, equipment, whatever it is, let your supervisors know. Use your chain of command. So always make sure that you have your charge nurse, you have your supervisor. If that's not working, come to me. If not, come to Lisa. Then after Lisa, go to Tammy. You have your chain of command, and in all the lunchrooms, you have your chain of command with pictures up on the wall so that you're able to see who is where. Be empowered, be a change agent, be committed, and be open to change. We all know that change is forever going to happen in our jobs. We are never going to stop changing in healthcare, and so just being ready to kind of take on these new changes and be open to the thought and the evidence behind it. Does anybody have questions or concerns about what's happening, what we've been working on? Okay.
Can I just add on what's coming? We kind of put together just a quick little thing with some educational items that are coming your way, some simulations, hemorrhage sims,
that's
things
good.
like that. So we have put it on paper so you have a date to go with it. More info to follow.
And I'm one of the clinical informatics specialists here at Providence. And I will be one of the people that will be supporting you guys. So if you do have questions about Epic, maybe OBIX is not working right with Epic, let me know. I do have a couple of cards if somebody is really interested. If you guys have a question, grab a card from me. Maybe in the future, I'm hoping to come to one of your meetings and maybe do like a quick session, 5-10 minute session, answer people's questions on Epic, maybe do a little educational piece on whatever you guys think is important for you. So I'm here for you guys. Let me know if you have questions. Thank you for having me.
Thank you.
Okay, so I am here to talk about columnar insulin order sets, and that's easy to say 10 times fast. So, I don't know, I think I've talked about columnar insulin a little bit, and so this is just me going into deeper dive. It's coming in a SAND release, which means that it's not going to be a big bang with an upgrade. This is just going to roll out. You're going to wake up June 15th and boom, it's going to be here in your Epic environment. So this is the formal education in regards to what you're going to see if a provider decides that he or she wants to order IV insulin on your diabetic patient. So, who remembers columnar insulin before? We've done it before, column insulin, an order set where you have columns of insulin. Okay, how, show me your senior nurses, come on guys. You guys,
I don't remember that.
really?
Not by
By columns?
No, we had a sliding scale that we.
Kind of like that, okay. So what I'm gonna do is I'm gonna pass around the columnar insulin so that you guys have a copy of it. This is actually built into Epic so that you're not gonna have to memorize this, so please don't try and memorize this, okay? Because it's readily available to you every single day of your life in Epic. But I want you guys to have a copy of this so you guys can play along with me as we go through this, okay? So, because it's really hard to read in the screens, okay? So here you go, it's two-sided. So here we go. So like I said, this is coming June 15th. And it's not going to come with a big bang, it's just going to be readily available for the providers to use as an order set. All right, so we always have objectives about why, and so we're going to talk about the advantages of why a columnar order set is good for our patient population, the appropriate rate for initiating and adjusting the insulin. We're going to talk about some documentation in Epic. We're going to talk about the hypoglycemic management in case our patients bottom out. And then we're going to talk about a couple case studies so we can actually apply this columnar insulin scale, okay? All right, so why are we changing? So why do we really care? Why would we want to do this? So, columnar protocols have the advantage of accommodating the rates of insulin infusion. So the biggest thing around this is that we can keep our patients from having these huge peaks and troughs. So right now, we don't have anything for our patients. If you think about it, what do we have for our current patient population? We don't have anything, right? Our patients don't have any order sets.
I thought there was one, because I had an insulin patient on Thursday.
There really isn't a great one though. It's not evidence-based.
She was on D5.
That was sliding scale.
But it's sliding scale. There's a lot of peaks and troughs that are happening. This is a lot more steady state, right? So it's more aggressive, so based on the movement of the your finger stick blood glucose, right? So it's evidence-based, it minimizes the risks of your hypoglycemia, minimizes the variation of practice. That's probably the biggest one right there, if you think about it. If we can get our providers to standardize the practice with this one order set, it minimizes our variation in practice. So we get our providers all in one place, our patients are doing all one thing. And then we achieve our target glucose range, which is really big, is we want to keep our patients in a tighter glucose range. It provides better stability for moms and for our babies. Okay, so this just shows you the order sets that we're going to use for our patients in kind of a summary, so that you guys, and this PowerPoint will be available for you guys on the FMC webpage, so please don't think about memorizing everything that's on here. So when we have a patient that's antepartum or interpartum, you're going to use this insulin columnar order set that we're talking about today. Okay? DKA should be managed with MFM consultation, and that there's actually a DKA order set available in EPIC. Antepartum patients may eat while on insulin infusion, and they have sub-Q insulin orders that are available. And then postpartum, there's a IV insulin adult order set available for those patients. Okay, so there are various order sets that are available for the patient population, but what we're going to talk about and we're going to focus on is our antepartum and our intrapartum patients. Okay? All right, this is why I gave you a copy of this, because there's no way you can see it on the screen. All right? So, the anatomy of it is that the biggest thing to focus on, we tried to highlight, is that we always start in column number 2. When we the columnar order set, is that we always start in column number 2. So if you have somebody that's above target, they're in this range up here. If they're in target, they're in the green zone. And then if they're below target, they're down here in more of the red zone. Okay? If it's in EPIC, you're going to see the colors. If you print it off on one of the printers in the unit, it's going to be in black and white. It's going to be a little bit harder to see because you're not going to have the color there. So visualization in EPIC is a little bit easier. At this point, they're not printed off on the unit. That's currently the decision. If there's a lot of concern or questions around that, we can sure print some off, laminate them, and have them available on the unit if that's what the staff decides. Okay, so hypoglycemia management protocol is built in. If you look at the bottom of your insulin columnar protocol, it's actually printed on the bottom. So you'll see it on the bottom of it. So if a patient were to go below 70, it's automatically there. Your insulin would be turned off, and then you have your management orders right there. Okay, and it tells you exactly what you're going to do with your patient.
Amy, can I ask a question?
Absolutely.
So you were talking about antepartum management of
Correct.
patients and patients that are on like diets?
Correct, and we'll go through that a little bit.
Why are they on IV insulin if they're...
There are some hospitals that manage their patients with IV insulin, and then they have them on oral foods, so they're eating foods at the same time as well as having an IV insulin drip. So they have very critical diabetic patients. So they have like brittle diabetics. St. Vincent is one of those hospitals.
So is there a criteria, like who is the person that, or who is deciding like that we even need to begin this?
So it's going to be your obstetric providers. Down at St. Vincent, they have maternal fetal medicine doctors that manage their inpatient patients. We don't have that here in our facility. I don't see us using the IV insulin orders on our antepartum patients, I see this being used more frequently, I would say 99% of the time, on our intrapartum patients. Because that's where we typically use this order set. So I don't see the antepartum patient population having this order set ordered, if that, so does that help answer your
It does a
question?
little bit, because I'm
Yeah,
confused.
I don't think our OB providers are going to be comfortable using this order set on an antepartum patient as often, routinely, because if they're that brittle, they're probably going to be sent somewhere else.
Yeah.
Yeah.
Good. got it. Thank
Just
you.
at this point in time, just because they're not comfortable taking care of that brittle with a diabetic at this point. Yeah. All right. Any questions or concerns about the hypoglycemia management? It's pretty standard management orders, but we will go into this a little bit as we go down the line. Okay. All right. So when to initiate the OB columnar insulin. Typically, this is not going to be on the nurse's shoulders. This is going to be on the provider's shoulders, right? This is not typically something that you call the provider and say, hey, let's initiate these IV insulin orders, right? You're going to see this on your type 1s. You're going to initiate right away because these are insulin-dependent diabetics, right? Type 2 and GDMs, it's typically, you're going to do it mostly when the patient can't control their blood sugars at over 120. Okay. And then in Oregon, they're doing it with a nurse communication when the blood sugars are over 120. But that's not going to be our world. Typically, it's just going to be a provider that's going to be ordering this, and we're going to be saying, okay, let's do this. Okay. Frequency of finger stick blood glucoses prior to drip per provider order. In our world, it's every hour once an insulin infusion is going. That's our standard, and it'll be on the order set. You'll see that. All right, so here's the order set, and it gets easier to see once you're actually in Epic. It's harder on a PowerPoint to read it, but once you're in your active orders, it's a lot easier to read. But these are your nursing process instructions. So this is your blood glucose every hour or more frequently if you need to. So of course, if your patient's appearing hypoglycemic, it gives you that parameter to go ahead and check one, okay? And then it talks about the documentation about the columnar insulin, okay? And then it talks about the administration of the insulin. And it tells you, they built in how to go ahead and prime your tubing. So most of you know how to prime your tubing for an insulin infusion, but because this is such an infrequent event for a lot of people that they don't do a lot of insulin infusions, we left that in there so that people can remember how to, kind of as that cheater guide to how to prime your tubing. So it basically is to prime your tubing with 20 mils of insulin solution every tubing change. Do not use filter or filtered tubing sets with the insulin infusion. And it should be placed piggyback into the IV fluids using IV infusion pump capability of 0.1 milliliters per hour. So it's basically the cheater guides, especially for those newer nurses, basically to not use the filtered sets and that kind of thing, to just that cheater guide for them.
So I've got a question about that.
Yeah.
So which, because it's been a long time since I've done an insulin drip, but which port are you going to be plugging into? And are you going to be using a micro drip tubing?
No.
Nothing with a filter, no, so not
Okay.
the micro drips, so not the filtered sets. A micro drip would have a filter on it.
Okay.
So, and you can just go, I would say that, you know, you can go, any port is great for you, but you would just want to make sure it's very well labeled so that if you need to disconnect, especially with your labor patients, you know which one you're disconnecting quickly. But insulin is,
Closest port.
yeah,
I think it's second,
Yeah.
we had 2 IVs the other day, because I
Yeah.
was told that you can't have pit and
insulin, you can't, that is a, thank you, that was one thing I was just about to say.
Pink line with her pit side,
Yep.
was they used pink Coban, and they had a green line for her insulin side.
Smart.
Her arm wrapped green with the other side.
know.
You can't, and
I
that
walked
is
into
very,
it, it
whoever
wasn't
did
mine.
that was very smart. You cannot mix Pitocin and insulin. That is the one thing you cannot do.
Who
Yeah,
did that?
let me think about it.
Let me know.
Kudos to them.
Just know we have those stickers
Yeah,
that you can put to the lines.
No, I'll think about it. I can't remember, but maybe.
Yeah, but that is, and the closest port is probably better.
Right.
It doesn't matter in the sense of flow, but the closest port would be the fastest out. Does that make sense?
Especially if you're
If
running
you're needing to get rid of it out of the
a
system.
TK.
Correct.
Because and you're not going to be using this. I would call this, instead of columnar, to me this is a sliding scale like we used to use.
You can move up a column if you.
Right.
Correct, right. But it does seem, for those of us who have been doing it forever, it is like sliding scale, right?
So what I most run into instead of an insulin drip is somebody who has an insulin pump and is managing their own insulin by their app on their phone and dialing in their insulin pump.
Pretty
So
crazy,
they
right?
Disconnected my patient's insulin pump the other
To
day.
switch over to
switch over because she
this?
needed a glucose drip.
Okay,
Because she was NPO, because she
makes sense.
got
Yes.
them.
So, and you will run, so that's another great question. So if you have a patient who has their own pump, that they're running their own pumps, we need to be sure what the plan of care will be, because sometimes, because of the labor process, they aren't able to manage their own. And so we will have to be very sure that that is turned off, unplugged, whatever it is, and then we're managing with our own insulin.
It was disconnected, we
Correct.
delivered, we put the insulin in the bag and put it in the black box in the soil utility, and then she reconnected
back.
to her.
Perfect, awesome. Yes, and then that was a great thought process around marking the arms, because you cannot put
We use a
it
pink
in.
sticker on the Pitocin.
Right, which
So
is
she
like
put
our
pink
old
on
school
that
way,
one.
absolutely, with pink and pit, so, yeah. Awesome. So, the order set, just know fluids are not pre-selected. It's a lot like any of our order sets, fluids are not pre-selected. It's the same thing with this one. Fluids are not pre-selected on this order set. So it's sodium chloride, so it's NaCl, right? And then it's dextrose, so D5.5 or D5 and sodium chloride, and then potassium. So it's so they need to make sure, they, being the providers, need to make sure that IV fluids are selected. So because you are not mixing, because you have an intrapartum patient, you need to make sure that you also have your fluids selected as well, okay? So something to remember is making sure you have fluids selected. All right, accessing the algorithm. There's a little link in here, and there are multiple ways, so don't think that this is the only way. You're like, oh my God, that's so small, there's no way I'm going to remember that that's in there. But there are multiple ways to access the columnar insulin link. So it's built within the insulin infusion hyperlink within the order set, and then it's also built in within the actual order, so multiple places, and that's what opens up into this, okay? As well as, for those of you who are very familiar with your OB navigators, okay, so OB navigators, and your protocols that are in that top banner, where you get your mute protocol, your postpartum hemorrhage protocol, all of your protocols, you're now going to have one for your insulin columnar protocol, and this is also built in there. So that's now 3 ways to get a hold of this thing, okay? All right. So, 4th way to get a hold of it is through your MAR. Okay, so now that's 4 ways to get a hold of your columnar graph. So, which is good because we all need different ways to get a hold of it. Okay. All right. So make sure that all other insulin is discontinued. We talked about that. Make sure if she's got a pump or anything, make sure that that's discontinued. 2 IV sites, because you can't run PIT and insulin in the same place. Make sure they have a maintenance fluid with dextrose, because of course if we bottom her out, we want to make sure that we can bring her back up.
So why in that order set is normal saline one of the options?
Isn't that interesting? Yeah. It really shouldn't be, but that's a great question, because if you bottom her out, you got to be able to bring her back up. I think they give that opportunity because there's the thought process that some patients will be able to have PO, because this order set is for antepartum patients that are on nutritional, that are eating, and they're appropriately eating. So they'll be able to, if they're hypoglycemic, have a non-diet soda, or they'll be able to have some glucose gel or something to bring themselves back up. But there are going to be those patients that can't, and they're going to have the dextrose, and they're going to have to bring themselves back up for
Pre-IV to bolus for pre-op is
Well, you're
fine.
gonna hang a second.
Right.
You're gonna
Yeah.
have a second.
Right.
Anyway.
All right, so we talked about flushing with the 20 mils of insulin through the tubing. 2 licensed nurses. So this is just that it's a high-risk medication, so you gotta have 2 nurses to double check your insulin, right? And then always start on column 2. So that's why it's highlighted in the columns, is that we always start on column 2. That's where we're gonna start. And it's based on what your patient's blood sugar is. So if you look on column 2, so I'm gonna throw out a number to you. Column 2 and your blood sugar is 230.
3.4.
3.4.
Thank you very much.
So why would, so maybe this is self-explanatory, but not to me. So if you start on column 2,
Yes.
okay, so then you check the blood sugar the next hour, and it's still 230. Then do I jump up to the 5.1 in column 3?
So if you're still, no. So if you're still 230, you stay the same.
So then when do I go, when and why do I go up?
When do you go to the next
When
column?
I go to the next column. So wouldn't I give her more?
So increases to higher one, no, I take it back. You go up to high, you go up, blood glucose remains in the same row, or increases to a higher one, move 1 column to the right.
Okay.
So you
Okay.
do go to the 5.1.
Okay, now I get it.
And you had some scenarios. right?
Yeah,
That
and
might
we'll,
help.
and we'll, Mrs. Jackson's coming up, so hold on
I
just a
think that'll
second.
help to
All
walk
right.
through that.
So finger stick blood glucose every hour, or more frequently if indicated. 70 to 120 is our tight window for our patients. If you have, this is a good thing about our patients right here, is that if they stay for 4 consecutive hours in this period, you can go every 2 hours. Likelihood of this happening with our labor patients is pretty small, so we'll probably end up staying every hour, okay? If you're out of these ranges, of course, you're gonna notify your provider. Okay? All right, provider notification, less than 70, greater than 190. If you're not able to obtain or maintain a blood glucose at less than 120 within 4 hours. And then, of course, if you have ketones in the urine. So if she's peeing and she has ketones in the urine, that's just, and that's typically on admit, if we do a urine, that we don't always do urines on our patients.
Right, I was gonna ask you about that.
We don't always do urine. We don't always do urines. Yeah. We're not going down that path again. But if we did a urine on a patient.
If we ever did.
If we did, okay. So, we're gonna talk about Mrs. Jackson here. So we're just gonna run through a case with the column, okay? So she's 32 years old, type 1. She's 38 weeks gestation. She's been in PO since midnight, except for some water. She's admitted for induction of labor with PIT. You check her blood glucose on admission, and it's 246. So the columnar insulin order set is in place. So where do we begin?
3.4.
All right, good job. All right. All right, an hour later, her blood glucose is 224. What target zone is this in?
5.1.
What target zone?
So next zone, gotta move up.
So the next hour, so she's now
It's in the yellow target zone.
224.
It's above target.
It's definitely above target.
Now you're gonna go to the 6.8, because you're still in the same zone.
Oh, we moved up now. She shifts one to the right because her blood sugar, her blood is above now 5.1. So remember, you were just asking that one question, remember?
Yeah.
So she's now 5.1, so it's just like exactly how you were, exactly what you just said, right? Because you'd ask that question, if she hadn't changed, it moves one to the right, right? All right, my numbers are off here. I meant to go, my things,
I see.
my colors are off. It's supposed to be up, my green is supposed to be up, and my blue is supposed to be up.
So,
So, 5.1, just look at the white box.
okay, got it.
Okay, 5.1.
Yeah.
All right. An hour later, her next blood sugar is 162.
Zone 4.
Okay?
Yeah, you can stay in the same
Oh, you stay in the same column.
You stay in the same column, so you go to 4.
No, you go to 3.
Because we have to know rows, targets, columns.
It says if it goes.
Okay, you want me to go back?
No, got it.
I did.
Okay.
Yeah.
So 162, what zone, column, rate?
Something above target zone.
But if it stays,
But it didn't increase
if it
to another row.
decreases to a lower row, stay in the current column, so it should go to 4.
No, because we never made it up to.
We didn't move up to column.
Oh, we didn't make it to that.
No,
Oh,
we didn't.
okay. Oh, no, we were in 5-1, sorry.
Some mistakes happen, I just want you to know.
So does that make sense how she decreased her blood sugar down to 162?
So she can stay right
So she stays, so, and you look in that little cheater box and it says, if blood glucose decreases to a lower row, stay in the current column.
Got it.
Okay, so she stayed in the current column, so now she's 3.
Yep.
Okay?
Yep.
All right. An hour later, Mrs. Jackson's blood glucose is 118.
In target.
She's in the green zone.
1.8.
Okay. All right.
Stay in the same column, 1.8.
Yep.
All right. You guys are getting this. I love it. You guys are getting this.
Now you're gonna
Love
love
it.
We haven't killed her yet. I'm just happy about that.
Hallelujah.
All right. I love it. Okay. An hour later, her next blood glucose is 103.
1.3.
1.3.
Yep.
Beautiful. All right. So, some signs and symptoms of hypoglycemia. You all know these ones.
Yeah.
You all get these ones sometimes when you guys don't eat, right?
Yes.
That's what I do. Thanks for the pizza.
Okay.
Where'd that go?
All right, here's it. Pizza, yes. Pizza on Friday, right? Okay. Yes. Friday was Friday. Friday was Friday. Okay. All right.
I haven't lost
So
consciousness yet.
here's the hypoglycemia management. It is in the order set. So it's all there. It talks about the point of care glucose, it talks about the dextrose injection that you can give. It also talks about the D10 infusion that you can give. So it has the order set built in there for you guys, okay? All right. It also talks about how it's built into the bottom of the columnar protocol, all right? All right. Guess what? Her blood sugar is 64.
Oh my God.
Way low.
Turn her
It's
off.
5 grams.
Okay, so now what do you do?
So do we have this glucose gel in the Craigslist?
Turn off the insulin.
So what would you do first and foremost?
Well, I would turn off the
Turn off the insulin.
Okay. So her rate now is 0. And then what would you try and do?
feed her if I could.
Correct. So the first step would be you would try and see if she can take something orally, right? You would see first and foremost if she's able to take something orally. If she's not, then we would
So she's
proceed.
been NPO since midnight. Does she have an NPO order?
She's in labor. She's in induction to labor. So you could try and give her something to eat. It's okay. She's clears would be fine.
Okay.
As long as anesthesia doesn't
Okay, as long as anesthesia doesn't kill you. Right. Hypoglycemia treatment, you guys did that rate off. If NPO, you could do 25 mils of D50 over 2 minutes. If able to take PO, you could do the glucose gel or juice or non-diet soda or milk. And then you'd recheck your glucose, right?
So is the gel that fixes?
I will check on that one, but it should be because it's an emergency med. Yes.
Is it the same?
Isn't the same as the babies?
You could use that one, yes.
It's probably
It's the same
wouldn't this be a larger?
It would just be a larger dose.
Yeah, it's the same stuff though, right? 15 grams of gel.
I would have to check though if you could use the same stuff. It may not be the same brand, so. Okay.
Is it based on the weight of the patient, the 15 grams? 'Cause the babies
No,
are-
it's just a straight, yeah. All right, she's 82 now. She was in column 3.
27.
Oh, then go to 2.
She was in column 3.
You go to the left, right? Resume it.
Oh, if they go low, decreases.
Stop insulin and versus 7 or above, insulin infusion, 1 column to the left.
Oh, to the left.
So we're 0.5. What is it?
0.85.
Because it's 82.
82. Okay.
So does everybody understand that? Because you had to move 1 column to the left because she was in column 3 to start with. So you just have to remember where she was. And I'll show you really quick, okay? So here's quickly through the documentation. Okay, you guys know how to get to the MAR, okay? You guys know how to get there. This just talks about where the columnar, this thing is. Okay? Rate dose change, it's a dual signature. Here's your rate change. Here's a comment. If they're eating food, okay? But that's if they are. We probably are not documenting. But just so you know, this is where you do your rate dose change right here. And then, I didn't point this out, sorry. Your column number's right here. Does that make sense? I forgot to say that. So, dose change, column number. So if you forget where the patient was, so if she's hypoglycemic and you're like, I can't remember where she was, go back to your MAR and it'll remind you where she was on the column, and then that's when you would restart her, okay?
That's something we're putting in there, the column. I mean, that's
Correct. You're putting,
auto-populating,
no, it's not
right? Like,
auto-populating. You're putting in the column. So that's where you would go back to refresh your brain where she was. Okay? All right. It's gonna take a little bit to get used to this. It's not easy to remember. Just know that we don't use it very often. It's gonna take a little bit to get used to. It's gonna take a little bit for the providers to get used to it. But we're here to help you get through this. And so when you do initiate it, or it gets initiated for the first time, let us know. We're here to help you, okay? We'll walk through it with you, okay? It's a slow process. We'll help you get through it.
You show them MAR again so people can see where you're ready to
Oh,
call.
absolutely. So column number is there, Kim?
They were in.
Oh, okay.
Column number, rate number,
And then it'll be on the MAR.
blood
Okay.
glucose in the comment box,
Okay.
okay? So you got all 3 there. And then if you happen to want to pull up the columnar thing, it's right there too. Okay, it's all there in the MAR for you. All right? So, and call on us. I'm on 80551 now. I do have a Spectra link just for me. That's always me now. So you can always call me. Okay? All right, guys.